Good morning, my dear friends. Today I will discuss about two-dimensional imaging modalities which are used in the dental implantology. Basically, detailed description of the intraoral projections which are commonly used in implantology and extraoral two-dimensional projections which will be discussed in the following sessions. Two-dimensional imaging, as name indicates, one can view the image in only two dimensions, where mesiodistal length and superior-inferior height can be measured, but not the buccolingual width. For preoperative implant evaluation, only mesiodistal and superior-inferior directions can be evaluated with these two-dimensional images. These two-dimensional images can be categorized according to our convenience into intraoral radiographs and extraoral radiographs. Intraoral radiographs includes periapical radiographs and occlusal radiographs, whereas extraoral radiographs includes panoramic radiograph, lateral cephalometric radiograph, and conventional tomography. In intraoral projections, the image receptor is placed intraorally and direct exposure to the image receptors takes place. Here, we shall discuss about the periapical projections. These radiographs produce a high-resolution planar image of the limited region of the jaws because of direct exposure to the image receptor, which provides overall assessment of the quality and quantity of a small area of the edentulous ridge. Dentists are more familiar with the depicted anatomy and possible pathologies with this projection. Advantages include inexpensive technique, low dose of radiation to the patient, easy accessible for the patient, and highly detailed images are obtained with this technique. In addition, linear measurements in vertical and horizontal directions are accurate if paralleling technique is used, where the film receptor is placed parallel to the long axis of the tooth. Significant disadvantage of susceptibility to unpredictable magnifications can be minimized by using this paralleling technique. However, distortion is particularly accentuated in edentulous area, where missing teeth and resorption of the alveolar bone necessitates receptor placement at an angulation in relation to the long axis of the teeth and alveolar bone. In spite of high resolution of images are produced with this projection, there are certain limitations, like only small area of the jaw is visible where buccolingual width and depth cannot be assessed. Possibility of unpredictable distortion and magnification with this technique, which in turn results in inaccurate measurement for the implant placement site. Next, occlusal radiograph, as name indicates, it shows the occlusal view of the jaw. Occlusal radiographs are planar radiographs produced by placing the film intraorally, parallel to the occlusal plane with the center of X-ray perpendicular to the film for the mandibular image and at an angulation of 65 degrees for the maxillary image to the films. Occlusal radiography, as like periapical projections, produces high-resolution planar images. Maxillary occlusal radiographs are inherently oblique and so they are distorted. Because of this, they are of no quantitative use in implant dentistry, either for determining the geometry or the degree of mineralization of the implant site. Mandibular occlusal radiography is an orthogonal projection, thus it is less distorted projection than the maxillary occlusal radiograph. These radiographs have limitation of distortion and magnification, but advantages include overview of the mandibular width, that is buccolingual direction, and one can easily visualize larger area of the alveolar ridge in comparison with the periapical projection. Thank you.